Chapter 13, Part 2, Anxiety Disorders, PTSD, and OCD. Remember, this lecture is supplemental for the textbook. Anxiety is an unpleasant emotional state characterized by physical arousal and feelings of tension, apprehension, and worry. Anxiety puts us on physical alert, preparing us to defensively fight or flee potential dangers, and on mental alert, making us focus our attention squarely on the threatening situation. In anxiety disorders, the anxiety is maladaptive, disrupting everyday activities, moods, and thought processes. Three features distinguish normal anxiety from pathological anxiety. Pathological anxiety is irrational. It is provoked by perceived threats that are exaggerated or non-existent, and the anxiety response is out of proportion to the actual importance of the situation. Pathological anxiety is uncontrollable. The person can't shut off the alarm reaction even when he or she knows it's unrealistic, and it's disruptive. It interferes with relationships, job or academic performance, or everyday activities. Generalized anxiety disorder, also known as GAD, is characterized by excessive, global, and persistent symptoms of anxiety. It is sometimes referred to as free-floating anxiety. A panic attack is a sudden episode of extreme anxiety that rapidly escalates in intensity. Panic disorder is an anxiety disorder in which the person experiences frequent and unexpected panic attacks. In explaining panic disorder, we have to look at both biological and psychological causes, since they seem to both be implicated. Panic disorder tends to run in families. People with panic disorder are usually sensitive to the signs of physical arousal. According to the cognitive behavioral theory of panic disorder, people with panic disorder tend to misinterpret the physical signs of arousal as catastrophic and dangerous. After their first panic attack, they become more attuned to physical changes, increasing the likelihood of future panic attacks. A phobia is a strong or irrational fear of something, usually a specific object or situation, that does not necessarily interfere with the ability to function in daily life. Specific phobia, formerly called simple phobia, is characterized by an extreme and irrational fear of a specific object or situation that interferes with the ability to function in daily life. Generally, the objects or situations that produce specific phobias tend to fall into four categories. Category 1 is fear of particular situations: flying, driving, tunnels, bridges, elevators, even crowds. Category 2 is fear of features of the natural environment: heights, water, thunderstorms. Category 3 is fear of injury or blood, injections, needles, medical or dental procedures. Final category is fear of animals and insects: snakes, spiders, dogs, cats, slugs, bats, lions and bears and tigers. Oh my! Agoraphobia involves the extreme and irrational fear of experiencing a panic attack in a public situation and being unable to escape or get help. Social phobia, or social anxiety disorder, involves the extreme and irrational fear of being embarrassed, judged, or scrutinized by others in social situations. One way to explain phobias is by looking at learning theories. Classical conditioning may be involved in the development of a specific phobia that can be traced back to some sort of traumatic event. People with specific phobias may have developed a conditioned response of fear to a conditioned stimulus that is generalized to similar stimuli. Operant conditioning can be involved in the avoidance behavior that characterizes phobias. People with phobias may have negatively reinforced by the relief from anxiety or fear associated by avoiding the object or situation. Observational learning can be involved in the development of phobias. People with phobias may have observed and modeled the fearful reactions of others. Humans seem biologically prepared to acquire fears of certain animals and situations that were survival threats in human evolutionary history. Some previous anxiety disorders, such as PTSD and OCD, have different categories in the DSM5, but have an anxiety component. One of these is post-traumatic stress disorder. Post-traumatic stress disorder, or PTSD, chronic and persistent symptoms of anxiety develop in response to an extreme physical or psychological trauma, such as military combat, natural disasters, physical or sexual assault, random shooting sprees, or terrorist attacks. There are three core symptoms that characterize PTSD: frequent intrusive recall of the event, avoidance of stimuli or situations that tend to trigger memories of the experience, and a general numbing of emotional responsiveness, and increased physical arousal associated with anxiety. Several factors influence the likelihood of a person's developing PTSD. First, a personal or family history of psychological disorders, then the magnitude of the trauma, and finally, experiencing multiple traumas. Obsessive-compulsive disorder, checking it again and again and again. In obsessive-compulsive disorder, or OCD, the symptoms of anxiety are triggered by intrusive, repetitive thoughts and urges to perform certain actions. Obsessions are repeated, intrusive, and uncontrollable irrational thoughts or mental images that cause extreme anxiety and distress. Compulsions are repetitive behaviors or mental acts that are performed to prevent or reduce anxiety. They may be overt physical behaviors, such as repeatedly washing your hands, or they may be covert mental behaviors, such as counting or reciting certain phrases to yourself. People may experience obsessions or compulsions, but more commonly they experience both. Although researchers are far from a full understanding of the causes of obsessive-compulsive disorder, biological factors seem to be involved. A deficiency in the neurotransmitter serotonin, dysfunction in specific brain areas, such as the frontal lobes and the caudate nucleus, which is involved in regulating movements. This concludes this part of Chapter 13.